Hello friends, now we'll be discussing about amebiasis as a surgical aspect of amebiasis. So before starting, I would like to thank Chandana Shri Ma'am for sharing the wonderful notes with us, which are very helpful for revision. And the link for the notes is given in the description below. So without other delay, let's get started. So amebiasis is caused by Entamoeba histolytica, which is a parasite, and the life cycle of the parasite Entamoeba, where the mature quadrinucleate cyst, which is the infective form, is passed in the feces of the carriers, and from the fecoral route it is ingested, and these cysts are resistant to the acidic pH of stomach, and in the small intestine they go on excistation, forming the trophocytes. 8 trophocytes are formed from one quadrinucleate cyst. These trophocytes or metacysts are the vegetative form and are actively mobile. These trophocytes then are passed into large intestine. From large intestine, they may invade the portal circulation and get multiply in the portal triads trapped in the interlobular veins and infect the liver parenchyma, causing focal hepatocyte infarction and liquefactive necrosis. And bacteriologically, these are sterile. So most common site is the right side of liver, right lobe of liver, causing amoebic liver abscess. And as we see that the blood from the superior mesenteric veins runs into more direct course in the portal vein to the large right lobe. So it is most commonly in the right lobe and sometimes in the left lobe around 10 to 15% and is associated with multiple small abscesses. So extraintestinal amebiasis, most common site is liver, and from there it can pass across the diaphragm into the lungs or pericardium or into systemic circulation even in brain. Then it can go into binary fission, form cyst, and then go into stool, which can survive, where they can survive from days to weeks in the external environment and infect other organisms. If these trophocytes are passed directly into stool, they are destroyed when passed out. Even if ingested, they are destroyed by the gastric acid. So the stool trophocytes are non-infective form of the uh, amoeba. These can penetrate the crypts of Libercun in the colon and helped by the tissue lytic substance like the proteolytic enzyme, which is amoebic cysteine protease, and these penetrate the submucosa causing lytic necrosis resulting in formation of abscesses and which breaks down to form ulcer, amoebic ulcer. If it gets treated, it is resolved. It may cause uh, pericecal or pericolic abscess. It can cause hemorrhage. It can cause perforation and peritonitis. If continues chronically, it can form strictures, granuloma or amebioma. And these amoebic ulcer are flash-shaped ulcer in the submucosa, and most common site is the cecum, and second most common site is the rectosigmoid. Now we see the clinical features. Clinical feature in the intestine, we have amoebic colitis, which is generally gradual, starts over a period of 1 to 2 weeks with crampy abdominal pain, watery or bloody diarrhea, fever in some cases, tenderness in the left iliac fossa or right iliac fossa if it is cecum, and it is known as, when it is in the left iliac fossa, it is Sir Philip Morrison's point. Chronic amoebic colitis is similar to IBD, and there is recurrent episode of bloody diarrhea with vague abdominal pain or discomfort. And fulminant amoebic colitis, which is a rare complication associated with severe bloody diarrhea, severe pain, peritonitis and fever. Some factors which are predisposing is poor nutrition, pregnancy, steroid use, very young age, less than 2 years, and it can result in perforation, toxic megacolon, and is associated with high mortality, that is 40%. Amebioma, which is a less common form of the intestinal disease, form annular colonic granulomatous reaction to the organism, and it presents as a palpable mass in the right lower quadrant, and it can also mimic like CA-cecum. Amoebic appendicitis is very rare and is seen in very high prevalent areas. Then the extraintestinal amebiasis, that is amoebic liver abscess, where it is common in young adult males with history of living in or traveling in the endemic areas. Could be associated with or without antecedent amoebic dysentery and amoebic colitis. It will be associated with fever, night sweats, cough and abdominal pain. On examination, there would be tender hepatomegaly, bulging of intercostal spaces with or without jaundice, can complicate by rupturing and causing peritonitis. Abscesses are most commonly in the right side, in the upper aspect near the diaphragmatic surface, and abscess contain chocolate colored odorless anchovy sauce pus with this pus is mixture of necrotic hepatic tissue and blood, and it is bacteriological sterile, and the abscess wall may or may not contains trophozoite. When passing to the lungs, it can cause pulmonary amebiasis through the transdiaphragmatic spread and create hepatopulmonary fistula causing anchovy sauce sputum. Cerebral amebiasis could be abrupt onset rapid progressive disease causing death due to systemic spread of amoeba to the brain. It can also cause cutaneous amebiasis. And evaluation will be, in case of intestinal, we will examine the stool where we will see trophozoites and occult or frank blood, charcoal laden crystal, polymorphonuclear neutrophils. Sigmoidoscopic colonoscopy will show flask shaped or collar stud ulcers in the cecum or rectosigmoid. Biopsy or scrapings may show trophozoites, and it should be differentiated from inflammatory bowel disease. In case of liver abscess, the chest X-ray may show elevated right hemidiaphragm, subdiaphragmatic air fluid levels, pleural effusion, consolidating infiltrates. Ultrasound may show hypoechoic collection, more sensitive, also delineates contiguous organ extension in CT. So CT will be more sensitive and show organ extension. Aspiration from the uh, abscess will help us in microscopy and culture. Serological test which is commonly done, most commonly is the ELISA, enzyme linked immunosorbent assay. Others like indirect hemagglutination, latex agglutination, immunoelectrophoresis, counter immunoelectrophoresis, amoebic gel diffusion test, complement fixation, and indirect immunofluorescence assay. The serum antibodies appear 7 to 10 days after infection and may persist for years. So how do we treat this? Management will be for the intestinal cases, the luminal amebicides, that is deloxanide furoate, that is 500 mg 3 times a day for 10 days. Others like parmomycin or idoquinol, systemic amebicides like metronidazole, tinidazole at a dose of 750 mg TDS for 1 month or IV for 5 to 10 days. Surgery will be reserved in fulminant colitis for systemic amebiasis. We use dihydroemetin. Surgery reserved for emergency like the toxic megacolon, severe hemorrhage and perforation, where we have to resect and exteriorize, that is stoma formation. Amoeba which does not regress after medical therapy must be treated with colonic resection to rule out colonic malignancy. So in case of emergency or in chronic condition, we have to go for surgery. In case of liver abscess, a non-complicated liver abscess, we can treat medically both liver abscess and colitis with systemic amebicides, that is metronidazole, followed by 10 days of luminal amebicide, that is diloxanide furoate. Radiological resolution may take around 3 to 9 months. So when do we go for percutaneous drainage? That is deterioration in clinical condition despite adequate treatment, मतलब तबीयत बिगड़ रही है. Bacterial superinfection, high risk of rupture, that is old age, size more than 5 centimeter, or left side abscess, Left lobe abscess, indication for surgical drainage, that is ruptured abscess, impending rupture, inadequate catheter drainage. These are some indications. So this was all about amebiasis for surgeons or surgical aspects of amebiasis. And thank you for watching. Please like, share and subscribe. Keep studying, keep growing, and never give up, because great things take time. See you in next video. Thank you.